everyone for joining us today to discuss coronavirus pandemic response, the impact of economic and healthcare services on homeless veterans in America. I want everyone to know that this forum is airing live. It's an historic moment. I want to thank both Republicans and Democrats alike for making this possible. The majority and minority working in a bipartisan way. It is the first live, entirely virtual bipartisan forum for the United States Congress. It's the first one ever. So both sides, congratulations, everybody, for making this possible. COVID-19 has changed everything. Every American is affected, and America's veterans are not immune. In fact, veterans are facing unique challenges right now due to the global pandemic. But the challenges created by COVID-19 won't go away overnight. And in the wake of this pandemic, new challenges will emerge, and their impact could become just as severe as the novel coronavirus. There is no shortage of frightening statistics that point to how tough times are for countless Americans right now. Let me go over the very, very grim statistics. More than 55,000 Americans are dead from COVID-19. Nearly 7,000 veterans have tested positive, of which 435 veterans have passed away. And the necessary mitigation measures have resulted in 26 million new jobless claims in a month, including an additional 4.4 million just last week. These jarring numbers will impact veterans' lives for years, and that's why our work here today is so important. To those watching at home, I want to thank you for being a part of today's forum, and I hope this video forum finds you and your loved ones well. I also want to remind any of our viewers, if you are a veteran who is experiencing hardship due to COVID-19, please contact your local VA. VA is treating all veterans, regardless of their participation in medical care, or regardless of their participation in VA medical care or their discharge status. So I implore you to call and get the care you need. You can call from anywhere in the United States. Call 1-844-698-2311. That's 1-844-698-2311 to arrange for medical services. Today, we'll be addressing several issues related to veteran homelessness. First, the COVID-19 crisis has affected tens of thousands of veterans who were already homeless before stay-at-home orders were issued. Some services that serve homeless veterans, such as shelters, have had to close in places due to positive tests or lack of workers to support the population. Second, COVID-19 has brought our economy to a halt. Over the last month, 26 million of Americans have lost their job and are struggling to pay their bills. And they are wondering how they will pay their rent or mortgages. Congress has placed a moratorium on foreclosures over the next 3 months, but it's a temporary solution. Foreclosure or eviction could be a problem for countless veterans if more permanent solutions are not put in place. This crisis could force more veterans into homelessness, and we must act to minimize that impact. Learning what resources we can use to prevent homelessness in the first place is paramount. And one of the lessons learned during the 2009 recession was the value of aggressive action to prevent homelessness in the first place. This is something we should all heed in our work. It is 10 times cheaper to provide resources to prevent homelessness in the first place than it is to house someone once they have become homeless. In response to the 2009 recession, Congress acted in the first month of President Obama's administration to pass the American Recovery and Reinvestment Act, otherwise known as ARRA, which created the HUD Homelessness Prevention and Rapid Rehousing Program, otherwise known as HPRP. This program sent resources directly to local governments to help renters. This program, among other actions, resulted in an unchanged homelessness rate from 2008 to 2012. The recently passed CARES Act, which provided over $2 trillion in assistance in the wake of COVID-19, also provided $20 billion in support to VA to help our nation's heroes. VA was given broad authority to use this funding. As such, VA allocated $300 million to the Homelessness Program Office. Now, I remain unconvinced that this is anywhere near enough, and I hope our work here today moves us closer to what is really needed. Finally, we must dedicate resources in the recovery phase to reintegrate veterans into their communities. This Congress has now passed 4 COVID-19 assistance packages, but we have failed to provide our local governments and hospitals the resources they need to deliver our much needed homeless veterans. For example, the CARES Act included $4 billion for the Emergency Solutions Grant, which can be used by states and local governments for rapid rehousing programs. But this is only 1/3 of the need estimated by the National Coalition to End Homelessness. This is on top of the massive shortfalls states are facing due to COVID-19 response. The answer is not, as Leader McConnell has said, for states to file for bankruptcy. This is for Congress to set up. States are facing budget shortfalls in the billions. My own state of California will likely see the shortfall this year exceed $25 billion. If President Trump thinks the federal government is a backup for states, then it's time to back them up. I look forward to Ms. Monet's thoughts on how we can most effectively support states, but time is running out and we must act. I hope this becomes a real priority the next time we return to Washington to provide additional assistance. And I look forward to hearing from our witnesses what resources are needed. Again, I appreciate everyone's participation in today's historic forum, and I look forward to today's conversation. I now recognize Ranking Member Rowe for his opening remarks. Ranking Member Rowe.
Thank you, Mr. Chairman, and thanks for hosting this forum today that can be seen across the nation. It's great to see our colleagues all in good health, and I know we all look forward to getting back to Washington and working together. And before I begin my remarks today, Mr. Chairman, I'd like to take the moment just to acknowledge the toll that COVID-19 pandemic has had on veterans and all Americans, and quite frankly, the world. Over 180 countries have been affected by this pandemic. According to the latest numbers provided by the VA to the committee, as of yesterday, the department had diagnosed 6,065 veterans with COVID-19, and tragically, 452 of them have died since the crisis began. In addition, 2,153 VA staff members working for Veterans Health Administration have also tested positive for COVID-19, and 20 of them have passed on. I want to express my deepest condolences to the families of the veterans and the VA staff who we have lost. I continue to pray to God for the healing grace for them and their families. I want to express my sincere appreciation to the dedicated VA employees all across the nation who have continued to step up and care for veterans and support state and local response efforts as well, from housekeeping staff to the healthcare staff and all the way to Dr. Stone and Secretary Wilkie. I know that all of our VA employees continue to put veterans first and do everything they can to stop the deadly spread of this virus. Mr. Chairman, we know that the COVID-19 crisis has placed an enormous strain on everyone, and those strains are evident today as how Congress conducts oversight during the pandemic. The gold standard of oversight are in-person hearings with witness panels and a compromise of diverse perspectives. And I appreciate the unique challenges presented by the COVID virus, and that today's forum is an effort to respond to that challenge. But make no mistake, today's forum is not an equal substitute for an in-person hearing. As you know, our party leaders are in talks to develop ways to return to Congress and during the pandemic, and I appreciate your staff reaching out to the department late last week that I request in an effort to have the department's perspective presented today. Understandably, they were unable to send a representative on such short notice. I request that if this committee moves forward with additional forums, that we will collaborate to identify topics and witnesses. Turning to the issue we're discussing today, COVID-19 and its impact on homeless veterans, as home orders continue in many parts of the country, it's right for us to ask, how do you stay home if you don't have a home? What happens to homeless veterans who are not able to safely access shelters and other sources of housing and other assistance? And how has the $300 million that Congress has authorized in the CARES Act to support those veterans been allocated? And what additional legislative action is needed to help those still struggling? These are the types of questions I hope we can answer today. And I want to thank Catherine Monet from the National Coalition of Homeless Veterans for being here to provide the coalition's perspective. Mr. Chairman, I know that our staff is currently working on the possible additional legislative fixes for VA homeless program, and I look forward to considering them as soon as possible. And we know the best way to help homeless veterans is to work together, beat this pandemic by continuing to flatten the curve and reopen our country and get to work in our economy as safely as we can. And this is Mr. Chairman, this is a very diverse country. What happens in New York is very different than what happens in rural East Tennessee, where I am, and what happens in our state. So I think we have to take all those things in consideration as we go forward as a Congress. And I look forward to today's discussion, and I yield back.
Thank you, Mr. Rowe. Thank you, Dr. Rowe. I now recognize, I'd like to introduce Catherine Monet, Chief Executive Officer of the National Coalition for Homeless Veterans. Ms. Monet has served previously on the staff of the Senate Committee on Veterans Affairs and with the National Alliance to End Homelessness. Ms. Monet, you're recognized for 5 minutes to give your remarks.
Chairman Takano, Ranking Member Rowe, and members of the House Committee on Veterans Affairs, thank you for the opportunity to join you today. Homelessness, as you know, makes both individuals and veterans more vulnerable to highly communicable conditions like COVID-19. Here in DC, people experiencing homelessness made up 4% of the COVID deaths as of April 26, but they comprise only 1% of the city's population. As of April 27, 2020, according to VA and CDC's data, veterans right now are currently 12.5% more likely than civilians to pass away if exposed to the virus. So homeless veterans are truly at risk on both fronts. Of the cases in VA's daily report, we've been unable to determine how many are actually experiencing homelessness. We have reason to question the data's comprehensiveness, given reports that 30 individuals, the majority of whom were veterans, tested COVID positive at a GPD grantee's facility during the week of April 13, despite many being asymptomatic. VA's data, as of April 23 at least, showed only 16 confirmed cases at the Baltimore VA Medical Center because cases from the shelter were neither diagnosed nor treated at VA. More clarity is needed to understand the true scope of transmission in the veteran population, as there will be many instances across the country where veterans are receiving testing and care outside of VA. Better data would help VA identify and address racial disparities or place-based challenges that may exist in the identification and treatment of COVID toward outcomes that equitably center the needs of veterans of color and other vulnerable subpopulations. The pandemic has undoubtedly impacted veterans in a variety of ways, from making it harder to find shelter and housing in some communities to causing increased difficulties in accessing supportive services and utilizing HUD-VASH vouchers, to creating new mental health challenges for veterans feeling isolated in housing. There are already organizations committed to providing vital services on a day-to-day basis, but even they face pandemic-related challenges, from PPE and disinfectant shortage to identifying innovative ways to safely deliver services and construction stoppages, even slowing down affordable housing development for veterans. NCHV appreciates the $300 million of CARES funding that VA has allocated to homeless programs. VA has announced an additional $200 million of that funding is going to go to SSVF grantees, and these are well-established programs who serve veterans, and the additional resources provide some flexibility to truly hold the lines at the forefront of this crisis. Because if not prevented, widespread transmission among this population can quickly overwhelm VHA's inpatient hospital capacity unnecessarily. The housing and shelter system is a critical partner to support medical respite capacity for COVID-positive homeless veterans or for unsheltered COVID-negative veterans to self-isolate when they're clinically at risk. A GPD fix is needed. Social distancing requirements for safe operations require GPD grantees to reduce admissions in their current facilities by up to 75% in some of the most compressed facilities. The CARES Act did not offer direction to VA on whether there ought to be a maximum per diem rate payable to grantees. So we urge you to direct VA to temporarily increase the per diem rate to a maximum of 3 times the stay-at-home rate retroactive to the beginning of this pandemic. Grantees are truly struggling with unbudgeted expenses such as disinfectant, masks, gowns, sanitizer, and other related supplies that they need to operate their facilities safely. And these factors, coupled with reduced charitable donations, have truly created financial strain for these organizations on the front lines of this fight. Given the infection rates that have been documented in congregate transitional housing facilities across the country, any further delay is really just putting homeless service providers in the impossible position of making life or death decisions based on insufficient resource availability, since the money has not yet been released to grantees. We need more testing for unsheltered veterans and those in transitional housing, especially if their transitional housing facility is a congregate environment. The CDC has noted early testing of residents in congregate transitional housing is critical to reducing the rapid spread of the virus among a highly vulnerable population, given the number of asymptomatic carriers that we've seen during widespread testing. As more test kits are available to VA, they must be prioritized for populations that are at high risk, including those in the most congregate housing facilities we have. Now more than ever, veterans need exit plans that lead to permanent housing. Many PHAs have moved to remote operations and altered operations because of the pandemic. We need to do everything we can to get the voucher program moving across the country, and this committee truly has led on that front, but I think we need to double down and do more to ensure that we are putting people in permanent housing as opposed to in motels and hotels. Last but not least, the road to recovery is going to be long, so I hope you all are prepared. Avoiding a major increase in homelessness during 2021 will require significant investment in programs to serve homeless veterans. We support VA's proposed legislative changes and estimate a total need in excess of $1.34 billion, including funding for DOL and HUD. Extended unemployment benefits run for 39 weeks, so we anticipate a wave of veterans facing eviction or foreclosure as moratoriums are lifted by local governments. But there are several minor changes that can be made to programs to blunt the impact of this on veterans. Thank you for your continued interest in ending veteran homelessness and your partnership as we work collectively to lessen the impact that COVID-19 will have on veterans experiencing risk of homelessness.
Thank you, Ms. Monet, for your opening comment. I now recognize myself for 5 minutes of questioning. Ms. Monet, I've heard that medical facilities are turning away individuals who test positive and are asymptomatic, preferring to treat those who have life-threatening complications from the coronavirus. This creates an unexpected complication for homeless veterans who test positive and live in congregate transitional housing. Do you have a good accounting of how many veterans in transitional housing have coronavirus?
Well, that's a great question, sir. And I certainly wish we had a better accounting. I've got some anecdotal numbers from members that run in, the 30s right now, but I don't have any sense of how many of the people who, are veterans and in transitional housing have actually tested positive.
Thank you. Do you believe that VA is aware of many veterans in transitional housing who have the virus?
I think that VA is aware of the risk factors, but I'm not sure that sufficient testing is available such that they could do widespread testing in transitional housing facilities the way they probably should be.
Can you briefly speak to the importance of testing at transitional housing facilities?
Absolutely. So one of the things that the CDC found was that in shelters where they found a single positive, the transmission rate was lower when they conducted widespread testing and isolated all of the asymptomatic COVID positive veterans so that they weren't spreading the virus to other people who might be at risk. I think once you have one, you start to see the cluster effect pop up. And in some shelters, particularly up in Boston and in other places, they've seen actually a positive rate in the range of 60%.
Wow.
And largely all asymptomatic carriers in shelters. So given the way the shelter environment is compressed and there's just not a lot of space to isolate, I think testing is critical.
Well, how is VA coordinated with states to ensure homeless facilities don't become transmission points for the COVID virus?
So what I've heard from members is that coordination is different from medical center to medical center. So I've heard that there is coordination in certain states. I've also heard that in some states, your healthcare for the homeless facility might be a stronger partner than VA or your state Department of Health. I think it really just depends on who's got the resources in your community to meet that need.
Well, for instance, in California, we have a project turnkey with Governor Newsom, who has worked with hotels and motels to provide housing for the homeless, provide housing for frontline medical workers, and in many cases, people who need to isolate. The county where I live in Riverside, California, Riverside County has done the same. That's what I mean by coordination. It seems to me that the congregate housing with people with homeless people, homeless veterans testing positive, that we need to get them into a housing which allows them to isolate, not only social distance, but isolate.
I'd agree. I think that's absolutely the goal, right? Is keeping people safe, making sure that we've got the resources available to do that. I can tell you that, in VA's SSVF program, they've been using some of the funds that they just got from the CARES Act to really ramp up isolation, particularly for veterans who are clinically at risk. I think that the release of more GPD funding might help with that in the GPD population, but I think there's a lot of room for improvement in that area.
As we look at the variety of programs addressing veteran homelessness during COVID-19, can you describe how tele-resources have impacted short-term housing programs such as the Grant Per Diem or SSVF compared to long-term housing programs like HUD-VASH?
Yeah, so tele-resources have been incredibly important. There are a lot of shelter providers who have done their level best to move to remote operations so that they can keep as many of their case managers safe from the coronavirus as possible. So we've seen a lot more use of teletechnology for case management, both in permanent supportive housing and in, rapid rehousing and landlord engagement and a host of other functions.
Before my time runs up, I just want to know, has that made an impact on homeless veterans being able to access these services?
In some regards, yes. I think some older veterans have struggled with the technology. Others have thrived. It's very much a case-by-case basis, but yes, there's absolutely an impact.
Well, my time has run out. Let me move to recognize Dr. Rowe for 5 minutes.
Thank you, Mr. Chairman. And just a quick correction. I don't know that we know that veterans have a 12.5% greater mortality rate. We don't know what the denominator is. We haven't done near enough testing to find out what the prevalence is in the community. And I think until we know that, we need to just, like mortality rates you're seeing now, we don't really know what they are. I mean, as your testing goes up, you find more and more asymptomatic cases that are positive, the mortality rates will go down. And so I think we need to wait until we get more information. One thing very, very important, I think, for veterans, and is one area of concern, especially homeless veterans who don't normally file a tax return. How will they receive their COVID-19 stimulus check? And what are you telling your members about the best way to help ensure this population gets some money? And if they have dependents, certainly their dependents get qualified.
So we've been promoting a lot of the IRS resources around the non-filers page. I wish that there was a more seamless way to deliver those benefits, but unfortunately, that's the best information that we have right now to provide to veterans and our members.
Well, do you go, I know when we do point in time counting each year to estimate how many homeless veterans and homeless people there are in the United States, is there a way to contact those folks that way? Because I would think that someone who's homeless, this would be a lifeline. This $1,200 check, and is much more than that if it's a family that might be homeless.
Absolutely. I think that to the extent folks in our community are still doing street outreach, they're absolutely sharing information on the IRS stimulus payments and some of the other resources that might be available to veterans at this time.
Mr. Chairman, one of the things we may want to think about doing is whether they can extend this to find these people. This timeline that these checks go out. I think that would be hugely important. If you had no money, were on the street, $1,200 or $2,400 would look pretty good, I think, for you. One of the things that I would like to know, I've never been able to really find out, in our homeless population, where we live in Northeast Tennessee, it's a very minimal problem. When I was chairman of the committee, I visited Los Angeles, and it's a huge problem there. And I've heard numbers as high as one homeless veteran in 10 live in one county in California. And that veterans make up as much as 30% of the homeless population in California. And I really would like to know where our homeless population is. It's very much like fighting the COVID epidemic. When it's isolated in New York and where I live, it's a very minimal problem. I have counties that have one or no cases. So do you all know exactly where those veterans, those homeless veterans are, so we could focus those resources where they are?
So there is some government data on where homeless veterans are. It's the annual point in time count, and the point in time count is good in that it's a year-over-year comparison, but it's also got some weaknesses in that, you get what you count. And if your count is not of good quality, or if you're in a rural area, it's a lot harder to keep track. Generally, we rely on local service providers who know their population in greater detail. A lot of communities are adopting what's called a by name list, where they're looking at a community-wide engagement tool where they're case conferencing and keeping track of every single veteran or every single individual they're aware of that's homeless, and trying to make sure that they're meeting those needs and getting people what they need to get off the streets. I think in rural areas, it's particularly challenging because of the geographic spread, and because oftentimes you see a lot more, doubling up and couch surfing as opposed to unsheltered homelessness on the streets.
Here's what we found out. We have plenty of HUD-VASH vouchers. A couple of problems in that program is, one is finding people who will accept that much money for the housing. And certainly where I live, it's a lot easier than where Mark lives, where the chairman lives, and in New York and other places. So that's one thing. And number two, we as a committee are going to have to figure out how to get more counselors, more people who look after these. Apparently that's been very, very hard for the VA to do, is to find these folks that will manage the cases. And there's a huge turnover in that. So I think we've discussed this, and I want to just finish up. My time's about expired, but I want to finish up by thanking you, Ms. Monet, for taking this on and working with our homeless folks. And I think we're really going to have to keep a close eye on this going forward because of this pandemic. I yield back.
Well, thank you, Dr. Rowe, for your past concern as chairman when you chaired the committee by visiting Los Angeles, and your awareness of the tremendous challenge we have here in California. So I appreciate the work you've done. Ms. Brownlee, you're recognized for 5 minutes. Be sure to unmute, Ms. Brownlee.
Yeah. Thank you, Mr. Chairman, and thank you to you and your staff for putting this together. I really do appreciate it. And I thank Ms. Monet for joining us. And I wanted to shift the conversation a little bit towards women veterans, and particularly women veterans who face housing insecurity. And it always seems to be that we don't really have an accurate count of how many veterans are who are experiencing homelessness, or who are unsheltered, or those who are at risk for homelessness. And I wanted to know if you could speak briefly about why that is, and how we could do a better job in predicting those counts.
So that's a great question, Representative Brownlee. I think one of the challenges that we see with women veterans is that they don't oftentimes access VA services when experiencing homelessness. They may be doubled up, similar to what Congressman Rowe would see in rural areas. They may be accessing services through the continuum of care, or potentially through, domestic violence providers or others who may not be as tied into the network of services that are available for veterans. In terms of getting better counts, though, I think that there are potentially ways that we could look to engage women veterans in a more productive way, or in a way that would entice them into services and into being counted and opting in. Do you know what I mean?
Yeah. Yeah, well, thank you for that. The other thing, I chair the Women's Veterans Task Force, and we've heard from many women veterans really across the country who have told us time and time again that women veterans with children particularly tend to not access services. And the reason they consistently give is that they are fearful that they will be separated from their children. And so the question really is, can you kind of walk us through why this perception exists, and in what ways it's a valid concern, and in what ways it's a misperception?
Yeah, so I think it's an absolutely valid concern, right? When you're homeless, it is a hard time mentally. You're out there with your children, you're thinking about the child welfare system and whether you might be separated from your children or not. I mean, if I were in that situation, I would worry, and I would probably choose the same thing that some of these women are choosing. I think some of the challenge that they face is really that, like the broader VA system, the system was designed to accommodate single men. And so if you look at a lot of the long-standing shelter services that were available early on, a lot of what we had was to accommodate single unaccompanied males. And there has been a significant amount of change that has taken place in the last, 6 or 7 years to make services more accommodating to women and families. And I think what you see as new programs have been added on, so when HUD-VASH restarted and when the SSVF program came about, those two programs in particular have among the VA programs for homeless folks, they have the highest rates of utilization within the women veteran population, because you can bring your children along and you have private housing and you don't have to worry about keeping them in a shelter that might be crowded or unsafe or uncomfortable to live in with your children. But that truly is a concern.
Yeah, and have you, in your capacity, have you witnessed this happening where actually it's not a misperception, that it's actually happening, that women are being separated from their children?
I think what I've seen is sometimes women present thinking that they need shelter, not recognizing that there are other services available that could better meet their needs. So I think what I'm hearing more of is women potentially being told that they're not a fit for the program that they are maybe trying to enter into because it's not able to safely accommodate their children. So not necessarily that they're being turned away, but that they may be sort of redirected to other more appropriate services.
And have you seen, my time is almost up, but have you seen a shift, I guess, in terms of those providers that are out there trying to better accommodate women veterans and women veterans with families?
Absolutely. I think in the last few years, we've seen that increasing. And I mean, I can tell you, at least from NCHV's perspective, we've got a toll-free referral line, and we get a significant number of calls from women with children and male veterans who are, unsheltered with their families.
Yeah. Thank you very much. My time is up and I yield back. Mark, you have to unmute.
Thank you, Ms. Brownlee. Thank you. Ms. Bilirakis, you're recognized for 5 minutes.
Thank you, Mr. Chairman. I appreciate it very much. Thanks for holding this hearing. I thank the ranking member as well. And I appreciate Ms. Monet being here. And thank you for your testimony, Ms. Monet. I have a couple questions. Ms. Monet, you have described a situation where the additional funding provided to grant and per diem recipients could be spent very quickly if there is not a cap on the reimbursement rate. I share your concern, of course, as we want to make sure that we are appropriately providing funding to as many grantees as possible in a fair and reasonable way. What do you believe should be the GPD rate? And what is reasonable in your opinion? Give me your proposal as far as a reasonable pay scale, what have you. I think we all agree there needs to be an increase, and we have to take, of course, the cost of living is different in the different parts of the country. So if you could elaborate on that, I'd really appreciate it. And I know you've touched on it to a certain extent during this hearing. Please.
So that's a great question. And I feel like over the years, there have been a number of different ideas floating around as to how to make the reimbursement structure more equitable for providers. I think that we've been looking at a factor of 2 to 3 times the per diem rate. I think given some of the expenses we're seeing from our members, 3, I think, would be the floor if VA had sufficient funds to support that. We're hearing about huge costs from shelters that have had COVID positive cases that now are paying $1 per square foot to disinfect their facilities on top of, all of the other costs that are associated with running the program.
Okay, thank you. Next question. Once this virus crisis is behind us, how do you envision the services offered by the homeless veteran providers to be affected? And what do you see as the roles for both the providers and the homeless veterans themselves as they transition into a new post-virus reality?
So that's a really good question. And I think we're still grappling with what services will look like as we're learning from providers who are right now in the thick of, modifying their services and their operations in order to do what they need to do safely. I think as we continue to learn more about the virus and about how we can operate best, my answer may change a little bit. But I think for today, if you ask me, I think environments where we're placing people in permanent housing or transitional housing that is, spaced out, I guess, or where veterans aren't so condensed into one space would be optimal. I mean, I think in the ideal world, if everyone had permanent affordable housing and there was no need for a shelter system, that would be a really great pitch too, or a really great thing to have. But I don't know that we will get there. With your leadership, maybe we could, but.
Okay, well, thank you very much. I appreciate it. I yield back, Mr. Chairman.
Thank you, Mr. Bilirakis. I now call on Mr. Lamb for 5 minutes.
Thank you, Mr. Chairman, and I really appreciate Ms. Monet, you joining us today. First, I'd like to just recount, I spent some time today with the folks at Veterans Leadership Program here in Pittsburgh, which is kind of our main nonprofit, or one of them at least, for dealing with homeless veterans and taking care of them and trying to prevent the, ones that they've settled from becoming homeless again. And I just want to say, for any of the VA folks that are listening, they were extremely complimentary of the way VA has handled the SSVF funds that were in the CARE Act. I guess just recently dispersed. They felt like VA was reaching out to them and making them aware of the opportunities that existed, and they felt that the funding was a lot more flexible than it has been in the past. The way they kind of broke it down for me was that that funding should allow them to pay maybe 3 months of rent at a time for a veteran who's gotten behind because they lost their job or for whatever reason, to prevent evictions for when things really do get bad here. And so I just want to compliment the VA for dispersing the money quickly and in what sounds like a pretty efficient way. And then I just wanted to ask you, Ms. Monet, if you've seen or heard similar reports from around the country about the way the VA is getting this money out there, whether it's flexible enough, whether it's happening in the right way, and whether this report I've seen on the local level is consistent nationally.
So yes, and let me tell you, I love the Veterans Leadership Program as well. I love everything about your district, but we've heard really great things about, the way the SSVF program has gotten the funding out the door in a speedy way. We know the HCHV program has a tiny pocket of funding that I think they're trying to use in a very intentional way. And so I'm not sure whether that funding has been dispersed yet, but I think what we're hearing a lot of is grantees waiting to hear from VA what will happen with the funding that was allocated for the GPD program.
Great, thank you. And my other question really is, I think that the direction that testing needs to go next is the ability for teams of people to go out in the community and do testing proactively and not necessarily wait for symptoms or wait for people to come into a central testing center, so that we can really isolate outbreaks where they're happening in real time and try to prevent them from growing. So I guess, would you agree that these transitional homes that you're talking about for veterans are going to be an important place for us to be able to send testing teams because the veterans live in such close contact? And maybe you could explain, for any of our viewers on YouTube or for me to tell my constituents, maybe you could explain a little bit more about what that close quarters living is like in these places. Are people sharing bedrooms? Are they sharing bathrooms and kitchen facilities and things that really could spread the virus quickly, thus making it important that we do a lot of testing?
So yes, absolutely, I can explain. So there are a variety of types of transitional housing, and some of them are, single room occupancy type where you've got a bedroom, but you're sharing a bathroom or kitchen facilities. Others are more like apartments with multiple bedrooms where maybe you've got one veteran in one bedroom, another veteran in another bedroom, and you're, sharing your same common areas, your living room, your kitchen, your bathrooms, what have you. But then there are other facilities that are, a little bit bigger, more open bay kind of bunk bed style where you've got veterans that are in bunk beds that are maybe 36 to 40 inches apart. And the CDC guidelines say that you should generally keep heads about 6 feet from each other. So when you think about how you space people, some of them are trying to, make them sleep in opposite ways where one person's head is this way and the other person is that way, or trying to set up barriers in between the beds. You've got other facilities that just have cots or mats laid out on the floor in spaces and sort of in squares, and that's your square where you've got your mat and your belongings. So they can look a lot of different ways, and I think that's why it's really important to look at what we're doing to protect people who are in those facilities. I definitely agree with your assessment that these facilities will be important places to test, and I do think that we should start with the facilities that are the most congregate. So the most overcrowded or the most.
I agree. And I'm out of time. So thank you very much for those answers and your participation. And Mr. Chairman, I yield back.
Thank you, Mr. Lamb. Ms. Radewagen, you're recognized for 5 minutes.
Thank you, Chairman Takano and Dr. Rowe. Your leadership in putting together this forum today, we thank you. And Ms. Monet, thank you so much for joining us. Thank you for your work on behalf of homeless veterans and taking the time today to answer our questions. The current pandemic has interrupted our lives on an unprecedented scale, but I'm glad this committee has found creative ways for us to continue our work on behalf of veterans. The veterans in my home district, American Samoa, face many challenges, usually related to our remote condition, our remote location, and limited resources. However, I'm glad to say that homelessness is not one of those challenges. I believe the reason for that is our tight-knit community. We don't have a lot to work with, but we take care of each other. And I think we can all agree that attitude of caring for one another is more important now than ever before, especially for those most vulnerable in these trying times. Ms. Monet, in your remarks, you commented about the racial disparities seen in the identification and treatment of COVID-19. Can you please expand on these issues, and what have you seen in relation to this with your membership?
Yeah, so that's a good question. I think what we've seen, and the comments in my remarks referred largely to the broader population, where we've started seeing that in certain communities, a lot of the people affected by COVID tend to be people who look like me, right? People who are African American, maybe people who are Native American, who, have average everyday jobs, have to go to work, they're essential, ride public transportation, are also potentially impacted by the long-term impacts of systemic racism or colonialism or other things that just really cause them to be at higher risk. So when you look at how we need to think about a response, I think we need to make sure that the response that we're developing as a country is a response that truly serves their needs. I mean, I also think that we haven't seen a ton of data out there on the Asian American Pacific Islander community, but that is, I think, a data point that is of interest to us, because I think that there are in some communities where you see a larger AAPI community, there are certain sectors of that community that are at higher risk.
Thank you, Mr. Chairman. I yield back the balance of my time.
Thank you, Ms. Radewagen. I now call on Mr. Levin for 5 minutes. Mr. Levin?
Thank you, Chairman Takano, and thanks to my colleagues. It's great to see you, and I hope this is the first of many of these sorts of virtual meetings and hearings that we're able to do to move forward with our important work serving the veteran community. Eliminating veteran homelessness has been one of my top priorities since coming to Congress, and the issue's only become more dire as we confront the COVID-19 crisis. And while the CARES Act provided VA with substantial funding and more authority, it's clear that we need to do quite a bit more. As chair of the Economic Opportunity Subcommittee, I'm glad to be working in a bipartisan way with my colleagues to craft additional legislation that addresses the needs of homeless veterans and those that serve them. So I look forward to working with you and leveraging what we learn here today to build upon our current work. Ms. Monet, thank you for your partnership earlier this year as we fought to increase HUD-VASH case management funding for fiscal year 2021. Can you discuss how the COVID-19 crisis is further exacerbating existing staffing issues at HUD-VASH and how we can mitigate those challenges?
Absolutely. So I think that there have been some challenges related to COVID and just related to staffing in general when you look at, you know, the demand for case managers in certain communities and the limited number of people who are qualified to fill those positions. I think that as you see healthcare providers, you know, looking at filling critical needs related to COVID, we may not have as many, you know, social workers or nurse case managers or other people who are critical to making HUD-VASH work available. I think that staffing continues to be a challenge for VA. And one of the things that VA might consider looking at is, you know, utilizing their contract authority a little bit more and thinking about whether they can partner with local community providers to really meet the needs. I think that there may be some early discussions of some pilot programs in place, but I think that anything that they could do to accelerate progress on that would be really helpful.
Thank you for that, and we'll look forward to working with you on that. Today's discussion also reminds me of a statistic that we heard when we had a field hearing in San Diego addressing veteran homelessness, and I know Chairman Takano was there with us, and Ranking Member Bilirakis was with us as well. That to prevent a veteran from becoming homeless only costs 1/10 as much as rehousing the veteran once they're homeless and already in crisis. And you know, obviously the toll that it takes on the veteran beside the point. How critical is it that we get ahead of this problem with robust funding for effective prevention programs now as opposed to waiting until downstream?
I think it's absolutely critical. And that saying that you mentioned is 100% true. I also think that on that note, we do need to really hone in on HUD-VASH, because housing someone with HUD-VASH is much more affordable than putting them up in a motel for, you know, 45 days or however long is needed, because they're clinically at risk of contracting COVID. So I think that, you know, it cuts both ways, and that we've got to look at that not only from a prevention standard, but also from a crisis response type tool as well.
So we'll really appreciate your input as we work on the next bill to hopefully address this. Last question for you. In speaking to a lot of our local veterans since the pandemic started, it's very clear that there is a huge spike in mental health concerns. And that the VA, we were speaking earlier this morning with Secretary Wilkie, and they had mentioned the huge rise in telehealth visits for mental health. But what would you recommend we do proactively to reach out, doubling down to try to prevent mental health crises from becoming veteran suicides, particularly among those homeless veterans and those who are at risk of homelessness in the veteran community?
So I think there are a couple of things that you could do. And one of the big things that we look at is the significant overlap, right, in populations of people experiencing homelessness and people who experience suicidal ideation. I think there are some pretty stunning statistics that VA has around the risk of suicidal ideation spiking right before eviction. So I think to the extent that we can prevent homelessness and put people in housing more, that would be a really critical response. I think that also, continuing with telehealth and doing more to reach out to people and engage them in ways, even if you can't reach out to them in person, making sure that they feel like someone cares is important.
My time's up, but it's good to see my colleagues, and thank you all for making this happen.
Thank you, Mr. Levin. Thank you for participating. I now move on to call on. Looks like Mr. Muser, you are next.
Thank you, Chairman. It's nice to be with everyone. Ms. Monet, thank you very much for your testimony here. It's very educational as well as just very important for us to hear and I was going to say appreciate, but not so much appreciate, but take in and be reminded as to the seriousness of this issue that has existed for quite a while. My district is relatively rural. I have a number of small, we'll call them stress cities. Unemployment is a little bit higher in my district, particularly in the small cities than had existed in our previous economy. And homelessness is in general a problem. It is not an issue. It is not pervasive. I mean, we don't have dozens of people, for instance, but enough where it's not only sad, but we have a number of very good community groups that lean in and are dealing with it I think a pretty good way. Our Veterans Administration is the same. I have the Lebanon VA in my district, and I have the Wilkes-Barre VA just outside my district, and largely the same thing. They're not overwhelmed with homelessness. They've got Lebanon VA, anyways, got a on-site housing that they provide, I think, for up to 20 homeless veterans. And we have other outlets. We have a very good HUD. HUD is very responsive to our needs. We engage in building and getting housing and homes, and it's good, but it's not handling it all, not by any means. And so I would ask you, and with this crisis, by the way, it's that too hasn't really affected outside of taking in elective surgeries and that sort of thing. Our Veterans Administration, both of them have, they've had about 500 tests, about 50 positives, and this is sort of just an FYI. And it's sort of interesting that they're both about the same, about 20 hospitalizations, and each have had one fatality. Equipment and that sort of thing is okay. So that hasn't necessarily changed the dynamic of homelessness, but let's face it, this crisis has changed a lot of dynamics here. So clearly it must, and we just don't have the data on it. So you've answered a lot already and gave me, I've been taking notes on a number of the things that you stated. But for our community, Eastern Central Pennsylvania, type of homelessness, as I express, absolutely exists. Veterans are homeless. What programs can you suggest that are currently within the VA system that maybe we're underutilizing and we could maximize, and or what new initiatives would you strive to create if if you were in charge of my neck of the woods here as far as improving veterans' homelessness?
So that's a good question. And I will give you my top of mind answers and also offer to work with your staff later if you want something that's more in depth and, more cohesive. But I think that I would look at where your homeless veterans are coming from and how frequently they're flowing through the system. Meaning, is your challenge, if you're not making progress, is your challenge related to more veterans becoming homeless or homeless veterans getting stuck somewhere in the system as they try to exit to permanent housing? I think as you look at that, that will give you a better understanding of where you might need to create new partnerships, whether it's with health systems or, the justice system or employers, and also looking at employment and training for, a variety of reasons.
Okay. All right. Thank you. I really appreciate it. I'd like to reach out to you as we work towards improving the situation. So,
I'm happy to help.
Mr. Chairman, I yield back.
Thank you, Mr. Muser. I now call on Mr. Pappas for 5 minutes. Mr. Pappas?
Well, thank you very much, Mr. Chairman, and to the ranking member for holding this productive forum. And can't wait to either do the next one or as safely as possible get back together in person so we can continue to pay attention to the needs of our veterans across the country. Obviously, as we go through this pandemic, we think of it as a public health crisis, but as Ms. Monet has touched upon, it is a human crisis as well. And those individuals who are marginalized, who are experiencing homelessness, are disproportionately impacted by the worst impacts of COVID-19. Ms. Monet, thanks very much for your testimony today and for your constructive thoughts about how we need to move forward and address the needs that exist out there. I think we've all heard some of the tragic reports about the impact that COVID-19 is having on rates of domestic violence. Reporting appears to be down in some areas, but officials believe that this is likely because victims feel trapped and are afraid to try to get help while stuck at home with their abusers. Sometimes the safest place isn't for people to be at home right now, unfortunately. Women veterans experience high rates of intimate partner violence, which only increases their susceptibility to homelessness. So I'm just wondering if you might comment a little bit on how this will impact homelessness among the women veterans population and whether you expect to see increased rates of domestic violence among that population.
So I'll be honest and tell you I'm not a domestic violence expert, but I would say that based on my rudimentary knowledge, that's probably an accurate assessment that, there will be increases, and I'm hopeful that we'll be able to find housing solutions for anyone who wants to leave.
Absolutely. In your testimony, you point out that 15% of the veterans who are experiencing homelessness have an other than honorable discharge, and we know that means it's far more difficult for them to receive the care they need or to qualify for certain programs like those that help them find stable housing. So can you speak to the impact that COVID-19 could potentially have on this group of veterans?
Yeah, so I think one of the really great things that Congress has done is enhance their eligibility for a couple of key programs, right? So employment assistance, transitional housing, rapid rehousing, and homelessness prevention. But where I think we need to really start looking is with regard to permanent supportive housing, affordable housing that's targeted to veterans only, and other key resources that veterans will really need to stabilize in the wake of an economic crisis. One of the things that we know about this particular group of veterans is that because they have tended to be so disconnected from the VA system, they oftentimes are homeless for longer, have more severe health conditions, and are just facing many more barriers to stable housing. So to the extent that we can look at eliminating some of those barriers moving forward, whether it's via HUD-VASH or other programs, I think that would be really crucial to recovery.
Thanks very much. I was speaking recently with the director of my VA Medical Center in Manchester, New Hampshire, who highlighted that food insecurity continues to be a top concern among our veteran population, but also homeless vets, particularly the need to get to the store or to get access to food and supplies. Are you seeing this with your partners across the country?
So I think what we've seen is really innovative community efforts to serve those veterans, because transportation can be a big challenge in a lot of communities, especially for veterans who are in permanent supportive housing, where you're not in a shelter that provides you a couple of hot meals a day, right? You are literally on your own. You might be in a community where public transportation isn't running, or where there is no public transportation. And you've got to figure out how you're going to get food, how you're going to socially distance while you're getting your food. Do you have a mask? All of those things that just make it more complicated. So we've seen some really innovative work from communities in terms of, actually going out and delivering supplies and, what's needed to veterans to make sure that they aren't just hungry.
Well, thanks very much for your thoughts. We look forward to working with you, especially as subsequent legislation will be considered of how to expand on some of the funding that was allocated in the CARES Act to make sure that we're targeting it to those veterans who are most in need. So I yield back, Mr. Chair.
Thank you, Mr. Pappas. Mr. Rose, you're recognized for 5 minutes.
Thank you, Mr. Chairman. It's great to see all my colleagues. I hope you're staying safe and strong. Ms. Monet, thank you so much for taking the time today. I want to talk to you about telehealth. It's clear that is becoming more and more important, not only the VA system, but healthcare systems across the country. Can you explain to us how we can consider innovative ways to expand telehealth opportunities to the homeless veteran population?
Yeah, absolutely. I think there's a lot that can be done. A lot of, I guess, the thought process around telehealth really revolves around permanent supportive housing and how you can use telehealth technology to bring case management to veterans while they're at home in their apartments or wherever they're living. I think that in some communities, the distance between the VA medical center and where a veteran lives has been challenging for case managers, right? Because you're a case manager, you start at 9, you've got to drive X number of hours to go visit this veteran, X number of hours back. And it eats up a lot of your day when you're not really being productive. So I think telehealth, especially for permanent supportive housing, could be a major leap forward as long as the veterans are comfortable using it. I think that in larger permanent supportive housing developments, potentially allowing them to use a Tandberg from VA or something where veterans can just sort of pop in at their appointment time and maybe have someone to help them utilize the technology would be really great. But I also think that we've seen some really innovative support groups that have popped up for individuals, veterans, or civilians who are unsheltered, where they're all kind of utilizing technology and maybe meeting via Zoom to try and get each other help and just feel like they're heard and feel like they've got a community that cares about them. There's an organization called Invisible People up in New York that does a really great job at facilitating some of these groups for people who are unsheltered.
And I would ask the same question in terms of telecare management. I understand that there's interesting options, but do you actually feel like we should be feeling more of a sense of urgency, that there are some things that we have to do in terms of integrating technology into the VA's care management systems, its outreach systems, because this notion of having a model of care managers and nonprofit partners going out into the community may well not be something that can return for quite some time. So I guess my question is, what do you think we should be not necessarily just exploring, but what should we be feeling a sense of urgency around?
So I can tell you, I think there's a sense of urgency in the crisis, just because absent the technology, there is no access to case management. That said, there are some parts of case management that you just can't really, conduct via teletechnology, right? Like, it's one thing to check in with the veteran to make sure they're complying with their medications, that they've got food to eat, and that they're safe. But that doesn't necessarily translate into understanding whether the veteran is, really thriving in their housing, or whether they're maybe a veteran who is struggling to adjust to living inside and is potentially maybe exhibiting behavior that might make their ability to hold on to their lease in their unit challenging. So I think there are pros and cons, and we've got to be thoughtful, but in the midst of this crisis, there's definitely urgency.
Great. Thank you again, Ms. Monet, and I yield back.
Thank you, Mr. Rose. I now call on Ms. Luria for 5 minutes. Ms. Luria?
Well, thank you, Chairman Takano and Ranking Member Rowe, for bringing together the first fully virtual hearing or forum amongst our committees. And I think it's great that you've helped us lead the way in Veterans Affairs to do that. And thank you, Ms. Monet, for joining us today. And, one of the questions that I specifically had was about the social distancing requirements have mandated these shelters to reduce their occupancy, sometimes by up to 75%. And other than urging the VA to increase the per diem rate, are there any alternative non-financial solutions that could be considered to help maximize the ability of these facilities or shelters to house veterans, or to partner with other organizations within the community, or even a thing I'm thinking about now in a community like ours that has such a large tourism industry and so many underutilized hotel rooms and facilities? Like, are there opportunities for partnership, particularly during a crisis like this, that can, still accommodate a sufficient number of veterans, but that may be unusual or unthought of partnerships?
So yes, absolutely. I think that there is a significant amount of activity going on the HUD side with regard to utilizing funding for, isolation rooms in hotels and motels. I think the SSVF program, because they've gotten new funding released to them, has been able to move more aggressively on that than the transitional housing providers in the grant and per diem program. I think the one challenge that you'll see with per diem providers is that the daily rate of reimbursement is $49 and some odd cents. So if you are a really great negotiator and you've got a hotel that, truly needs the business, then yes, you can do that without, a huge financial toll. But you've got to think about, not only are you taking on rooms in a hotel contract to pay on a night by night basis, but you may potentially need additional staff to support care at the facility. You've got to figure out meals and some other things. So I think that's why we're really calling for the increase, because we do recognize that social distancing is essential, but that financially it's very hard for transitional housing providers to, be able to do that in a hotel or motel situation with the current rate of per diem.
Well, thank you for that feedback. And additionally, there were some changes and some relaxation of shelter absence guidance within the CARES Act. Can you talk about how that has been manifested, particularly in the different shelters? I believe it said that they should waive a requirement to discharge a veteran from the program if they've been absent for 14 days, and then also may continue to pay the per diem after a certain period of time, and that they've already been absent for 72 hours. And in addition to that absence, what happens when a veteran, may be absent but shows back up with additional family members, kind of dovetailing into what Representative Brownlee talked about with the shelter's ability to accommodate additional people or family members in a time like this.
So VA actually was really quick to issue guidance on those parts of the CARE Act, and I'd be happy to share that with you and your team. I think a lot of the intent of that guidance was really to ensure that providers wouldn't be penalized if, veterans needed to leave and isolate or potentially contracted COVID and needed to be hospitalized. Because one of the things that's a challenge is that there is a lifetime limit on the number of times that you can utilize the GPD program. So for a veteran that maybe has used his 2 of 3 chances, if he contracts COVID or she contracts COVID, has to leave for the hospital, they have to exit the veteran from the program. They aren't able to come back to the program. In terms of, coming back with families, I think that, there is no way that VA pays per diem right now for dependents. I think there's been legislation that has been floated for a number of years that NTHV does support. So I don't know that there would be an impact in terms of payments, but I think it would be very much on a case by case basis as to whether, the facility that they came back to was a facility that could safely accept children, right? So is it a bunk bed situation or a whole bunch of mats, or is it something where, you have more individualized housing and they can ensure the safety of the veteran and the dependents.
Well, thank you for that. I think we're out of time and would love to have that additional information if you are able to follow up with our staff. Thank you so much for participating today.
Thank you, Ms. Luria. I now call on Ms. Lee for 5 minutes. Ms. Lee.
Thank you, Mr. Chairman. Thank you for having this important forum today. And thank you, Catherine, for all of your great work on behalf of homeless veterans. I reached out to several of our partners here, nonprofit in the community, Shalimar Cabrera, who runs US Vets, and just to talk about some of the challenges they were facing. And US Vets operates over 330 beds of transitional permanent housing, and they've been forced to lock down their facilities and therefore have seen a significant increase in their operating costs. Instead, before they served 80 to 100 meals a day, now they're more than 150. They've had to purchase activity kits and PPE, et cetera, to help deal with their veterans during the lockdown. And while their organization is lucky because they've received a lot of donations for items such as toilet paper, other organizations have not been as lucky. Can you talk about ways that Congress can help offset some of these unexpected operating costs and what you're looking for in CARES 2.0?
Absolutely. So we've got some pretty aggressive asks in CARES 2.0. I think you are spot on. And, there are a lot of smaller providers than US Vets. We love US Vets in Las Vegas, and quite frankly, their whole family, they're NCHV members, and they're near and dear to my heart personally. But, there are a lot of smaller mom and pop providers who are really struggling. There are other providers who have also locked down their facilities and have now been unable to accept, meal donations where they would normally have corporations come in and provide breakfast daily or lunch daily. They aren't really doing that. And so they are seeing these really huge costs in unexpected ways that just haven't been budgeted for, because who could have really planned for a pandemic like this, right? So I think that to the extent that you all could work something out for the grant and per diem program, that is incredibly important. One of the other things that we asked for, and I'll be very honest, we put this out before we realized quite how dire the PPE shortage was at VA. But I think if providers were even able to purchase PPE from VA at cost, that would be a significant savings for them, because right now they're out on the private market competing with everyone else who's, looking at totally inflated prices, or potentially they're out in their community trying to buy it at, the local grocery store and waiting in line and competing against their neighbors for their 2 gallons of bleach that you can get a day, or whatever the limit is at the local store. So I do think that more needed in that area would be incredibly helpful.
Thank you. I wanted to talk about looking at what Congress provided already in the CARES Act with respect to homeless programs and the flexibility that we put in that. Shalimar stated to me that while they're flexible for her to put veterans into hotels or motels if they test positive for COVID-19, there's a worry about what happens when the economy opens back up. And Congress put a moratorium on evictions and foreclosures through June. However, once that moratorium's lifted, and evictions are potentially going to start to happen because veterans can't pay their rent, there's a worry that more veterans will require assistance and the system will become overwhelmed. Can you talk about ways that we in Congress can act now to ensure that that does not happen as the country starts to open back?
Absolutely. So one of the things that we've been looking at is providing some flexibility to the SSVF program to extend out the number of months that they can support, because I think there is a real fear that veterans, once the eviction and foreclosure moratoriums are lifted, will come in with significant arrears and will maybe potentially, because of the number of months they've been in arrears, only be able to access a month or 2 of temporary financial assistance to help them move forward in life. And we're not sure that that is enough. I think we're also looking at DOL's HVRP program because that program is really tied into the housing and homeless system in a way that, you know, your DVOPs and leavers aren't. And so looking at how we can tie those two programs together in a more efficient way to provide seamless services to veterans who, you know, are losing their jobs and are also housing insecure.
Great. We'll take a look at that. Thank you, Catherine. And Rashida, I'm really impressed with your innovation at your timekeeping. Thank you. I yield.
Thank you, Ms. Lee. It is impressive. They figured out how to do the clock up there and to keep her position stationary on the upper left-hand corner of our screens. Mr. Cisneros, you're recognized for 5 minutes.
All right, thank you, Mr. Chairman, and thank you, Ms. Monet, for joining us today and providing us with your insight into this important issue of homeless veterans. Ms. Monet, I live in Southern California, and we know about 1 in every 4 homeless veteran is residing in California. In Orange County, there's approximately about 3,500 homeless veterans that are residing here. In my district, in the city of Placentia, later in the year, they were planning on opening up a veterans village that was going to house about 50 veterans and also provide wraparound services to those veterans living there and help other veterans as well who might be looking for a job, for example. How are facilities like that and other facilities, similar facilities around the country, really going to have to, you know, how are they going to adjust, you know, in this new COVID-19 I guess, era? You know, they were going to provide services to really help veterans, you know, maybe with substance abuse or helping them find a job. But now it's maybe more about, you know, in this COVID-19 era, just about giving them shelter. How are these facilities going to change and how are they going to adjust?
So I think there are some key considerations that, you know, programs will have to make as they move forward. I think what we're hearing from our members who are really dealing with this head on is, you know, that they're going to have to look at temperature checks, more screening. Some of them are even talking about identifying additional space where they can isolate veterans who are coming into their facilities for 14 days before they come into transitional housing, just to make sure that, you know, they don't have anything that could be transmitted to other veterans. I do think that drop-in centers will look a little bit different. Transitional housing will look a little bit different. Some of the more community-based housing options maybe won't need to change as much, but there will be some significant changes that providers will have to think through as they look at, you know, our knowledge about the coronavirus growing and adapting our operations to that.
Do we think there'll be a drop-off in some of these wraparound services, whether it be helping these veterans with substance abuse or alcoholism? Will those tend to, you think, maybe drop off because of the concern around COVID-19?
So that's an interesting question. And I think a lot of my thought process around that depends on the physical layout of the facility. So for example, if you're a facility that is providing services, but every veteran has their own room and their own bathroom, I could easily see you making minor changes to, you know, food delivery and other assorted things, but being able to operate. But if you're a facility that is congregate transitional housing bunk bed style, then potentially, yeah, you may have to decrease beds or find more real estate in which to operate so you can serve the same population if the same level of need is existing.
All right. Well, again, thank you for your time. I can see I got like 30 seconds left, but I just want to thank everybody for doing this. It's good to see everyone. And thank you, Ms. Monet, for your insight. With that, I yield back.
Thank you, Mr. Cisneros. It appears that all the members that wanted to claim time have claimed their time. And I now would like to recognize Ranking Member Rowe, Dr. Rowe, for any closing remarks that he may have to make.
Well, thank you, Mr. Chairman, and I want to thank all the members. A great turnout today, and obviously we'd rather be back in Washington, D.C. working, but I do want to just give a little ray of light. I think we're going to turn the corner. I think we're beginning to turn the corner in the country. Obviously, we haven't faced anything like this in a century. Most of you don't know this, but the chairman and I, and now our subcommittee chairs, speak regularly with the VA secretary and Dr. Stone, who's Undersecretary of Health, and others at the VA each week. And I think our country has really reached out to our veterans to try to make sure that they get the absolute best care that we can give them during this pandemic. And I have to say, the VA has done a good job for the shortcomings. I know we've had shortcomings in testing and PPEs, but this really sort of caught us off guard. And I think we've learned a lot from this. But I am optimistic that we're going to return better and stronger. And I certainly hope that we can, and one of the dreams that we had when I first got on the committee, and I know Mr. Bilirakis and Chairman Takano, was that we wanted to eliminate homelessness among veterans. General Shinseki made that one of the things he wanted to do. He didn't succeed, but he reduced it dramatically. And I hope that this pandemic doesn't cause us to have an uptick in homelessness in this country. I certainly hope and pray that doesn't happen. My thoughts and prayers go out certainly to the people who've lost loved ones, and certainly people who are in the hospital alone because they can't be visited right now because of the pandemic. And I look forward to us opening our country back up again in the fall. And I look forward to football season where we can go see a football game and our favorite team. And I know Go Vols want to beat the Florida Gators in Alabama. And it happened in a long time, but we want to do that. And I think if we get back to more normal activities, people in this country will be happier. And I do want to finish, Mr. Chairman, by saying that I'm always amazed at the goodness of the American people, how they reach out to help their fellow citizens, whether it's bringing them meals, I see that done, or donating food at an animal shelter or at a food bank. A shout out to the greatest people in the world. And it's been a privilege for me. This is my last 6 or 7 months. It's been a privilege for me, my 12 years in Congress, to serve on this great committee, and I yield back.
Dr. Rowe, thank you for those very kind words and wise words. I called on you a bit too soon. I know that Ms. Underwood has returned, and so we're expecting Mr. Watkins to return. So in order for them to participate in this historic occasion, unfortunately, it's historic because of a great larger tragedy. So I'm going to call on her, and I'll give you a chance to say anything more you want to say toward the end. But Ms. Underwood and hopefully Mr. Watkins returns. So Ms. Underwood, you're recognized for 5 minutes.
Well, thank you, Mr. Chairman, and thank you, Ms. Monet, for joining us today. During these difficult and trying times, it's so critical that we leverage all available federal resources to protect vulnerable groups during this pandemic. The global pandemic has compounded existing vulnerabilities and highlighted the susceptibility of our homeless veterans populations. In some larger metropolitan areas, as you know, over 50% of the homeless veteran population has tested positive for the coronavirus. So Ms. Monet, what can our smaller communities do to best prepare for when COVID-19 inevitably reaches these vulnerable populations like homeless veterans?
So I think there are a lot of things that they can do to be proactive. If you're looking at providers parts of the community that are specifically serving homeless veterans, you can really start to think about how you would plan for a pandemic. What kinds of supplies would you need? How would you modify your operations? What partners do you need to have at the table to make sure that, if the inevitable happens in your community, you've already got relationships in place that you can capitalize on? I do also think that, looking at your resource availability and understanding where your gaps are and thinking through, what you would need to keep people safe in a pandemic would be a really important first step.
Yep, planning to care for them is the first step in being able to do it. Are there precautions that shelters that can begin implementing to prevent the spread of COVID-19 in their facilities, even if their communities haven't yet experienced significant spread?
Absolutely. And there are a number of veteran-focused shelters who are doing things like, locking down the population, not taking any new admissions, especially if they're, congregate and highly compressed in the facility. There are a number of other things that you can do with regard to, asking people about their symptoms. Maybe you don't have tests, but making sure that you're screening and assessing and sending anyone who might likely be a positive back to VA or to the State Department of Health or somewhere for testing. I also think that, organizations like that can be looking at, who in their population of veterans currently is at high risk of contracting COVID and thinking about alternate housing solutions for those veterans or prioritizing them for other programs or resources just to keep them safe.
Yep. And then I know that Congresswoman Brownlee asked about unique needs for female veterans, but just wondering what else we might be able to do to anticipate their needs, how we can care for them, and how we can make sure that they are being, thought of and planned for during this time.
So I think the only other thing that I can think of that I maybe didn't mention is, looking at what else we can do to support female veterans, because oftentimes female veterans who are experiencing homeless or, have kids, right? They're parents. So female veteran, 2 children, looking at, unemployment, housing instability. I mean, you've got to think not only about the issue from the perspective of finding them housing, but also how you help them thrive, whether that means that you're connecting them to employment that is suitable, or you're looking at what you can do to support them with childcare or, other things that will, allow them to more successfully be stable in housing.
Great. My office has been in close touch with the Veteran Assistance Commissions in my district who've mentioned challenges in conducting proper outreach to homeless veterans. What are you learning from larger homeless veteran populations that can be applied in smaller communities to effectively reach those folks?
So I think that there's a lot that you can learn from larger communities about outreach in particular. One of the bigger challenges that I've seen a lot of communities really overcome is building the rapport, right? So not only getting out there, but also knowing where to go and then knowing how to connect with veterans or, unsheltered people in a way that will encourage them to look into services or look into housing and, making services enticing.
Well, we know that during times of disaster, whether it's healthcare disasters and emergencies, economic disasters and emergencies, it's the vulnerable populations that see disparities get exacerbated. We want to make sure that our homeless veterans are being cared for and taken care of and are not experiencing a disproportionate disease burden or related impact. Thanks so much for your leadership and for being with us today. I yield back.
Thank you, Ms. Underwood. And Dr. Rowe, I know you already gave a stirring closing, but is there anything else you want to add before? I understand that our other member is not going to make it back, but Dr. Rowe?
No, not at all. Thank you, Mr. Chairman.
Well, Dr. Rowe, I want to thank you for working so closely with me on behalf of our student veterans. The Senate passed companion legislation, and the COVID-19 Student Veterans Protection Act was signed into law. That would have been would not have been possible without the work, the bipartisan work that you and I have done together. I'm sorry to say that we lost an American treasure that I did not know was an American treasure before this pandemic, and that's the folk singer John Prine. And Dr. Rowe, you and I have exchanged. I had a feeling, since you lived in Tennessee, that you probably had a good admiration for him, and I was right. And you have your guitar right next to you. You can close out. The Tree of Forgiveness. That was a wonderful song, and I've listened to a number of his compositions. And I'm sorry, I did not ever attend a concert in person, and COVID-19 and the pandemic have taken that opportunity away from us, and we've lost a great number of great Americans and people around the world. And I want to thank our veterans who have heeded the call of Dr. Stone. Dr. Stone, I think, posted a very poignant and moving call to our veterans to lead their neighbors in social distancing and the type of call to action that our governors have and local leaders have asked us to heed, which is to stay home and stay safe and save lives. And I want to also remind our veterans who are watching, you can call from anywhere. I said you could call from in the United States, but I think you can call this number from anywhere. It's 1-844-698-2311. Regardless of whether you are eligible to enroll in VA or enrolled now in VA healthcare, if you think you have the symptoms of COVID-19, the coronavirus, you are eligible for VA care. If you were a veteran, you're eligible. And that also goes for if you had an other than honorable discharge during this time of this national emergency, you're eligible to seek health care at the VA. And I want to give you that number again. It's 1-844-698-2311. So Ms. Monet, I want to thank you for participating in this committee forum. And I hope that you'll continue to work with the committee on this issue in the near future. I want to thank all the members of the committee for participating. I want to thank my Republican colleagues especially. This could not have happened without you. We have made an historic achievement here. Unfortunately, as I said, this achievement is occurring in the context of a great tragic pandemic, one we haven't experienced for 100 years. And so with that, I wish everybody, a happy rest of the day. And I do hope that you will heed your public health authorities. Stay home, stay safe, and save lives.